want to thank the organization committee for inviting me to present this talk. I was just reflecting back among the 20 years of the CSE. I believe I gave the workshop on this the very first year, so I thought I would just reuse some of the slides. These are my disclosures. I've had some working relationships with pharma. One thing that we need to remember is that the whole spirit of this talk and the mission of the CSE and the ASE is to promote the business, so it's good for patient care, it's also good for us, so that should be disclosed. And I also brought this as a prop. So I was there at the whiteout a few days ago, and unfortunately I'm going to miss tonight's game, but when you twirl this for the whiteout, you got to make sure you have the right side, otherwise you're just waving the white towel, much as what happened last night. Whoa. Thank you. I won't go over the various aspects of the echocardiogram exam in terms of the various components for mitral regurgitation, but I want to highlight a few things. A lot of this is from the ASE document from 2017 that is an extremely handy document to use. In terms of mitral regurgitation, Carpentier described type 1, type 2, and type 3, depending upon the leaflet motion, whether or not the leaflet motion was excessive is in type 2, restrictive in type 3, or normal is in type 1. And there's different categories of it within that. But I just wanted to ask, I know we don't have an audience response system, but maybe just from a show of hands or even just internally within yourselves, do you routinely report this in your reports? Yeah, so how many would say yes? So a small percentage, how many would say no? And I think it probably reflects upon who your audience is. If you're in a center where a lot of your audience is your GPs, they're going to just phone back and say, what's this Carpentier thing? You know, I'm not French. I think more importantly, though, I think knowing the Carpentier classification allows us to remember that looking at mitral regurgitation is not just how much, it's also how come. Why is there mitral regurgitation? How do we separate between a leaflet abnormality, or so-called primary mitral regurgitation, versus a secondary abnormality? Is the problem the annulus, the left ventricle or left atrium? And being able to distinguish that may have some implications in terms of sorting out what may happen, and also therapeutically what options may be available. And I think our next speaker will speak a little bit about that as well. So how many people would distinguish between primary or functional mitral regurgitation routinely in their reports? Small number of hands, and how many would not? And I would think that's one thing that going home, that would be helpful. At least in your description, distinguish whether or not you think this is a primary abnormality or whether it's a secondary or functional abnormality. You're right about the mouse. There we go. Okay, so let's show some examples and see what you think about. Geez, which? Oh, here we are. See what you think, but whether you think these are primary or secondary abnormalities. This is Friday the 13th, isn't it? You only get one look at it. This is like reverse Jeopardy. This is great. Okay. So how many would you think, how many people out there think that this is mainly a primary mitral valve abnormality just from the one shot? So how many would, again, in Jeopardy, you get very little time. So this is, how many people would say this is primarily a primary mitral valve abnormality from the images you've seen? Kwan's already seen it enough. You know, in 5 microseconds, already determined. Kwan, what do you think this is?
I would say secondary.
Yes, that's right. And Kwan's absolutely right. There was actually a wall motion abnormality describing, I believe, in that case. This is a slightly different case. This is a little bit more obvious, I think. So again, this the same kind of wall motion abnormality, a little bit more obvious in that case. I think as you get older, the letters get very much smaller. I can see why a lot of people use their laptops. Yes. In clues in terms of determining whether it's primary or secondary, you just want to look at the leaflets. Are the leaflets a little bit thickened? Are they nodular? Are they calcified? The big question that I ask my sonographers and my students is, does the mitral valve look any different than somebody else of that age? And is the regurgitation kind of what you expect for someone with that age? Or is there something more than that? And I think that helps distinguish it. Some of the other aspects they'd look at is, what does the annulus look like? What's the closure point of the mitral valve in relation to the annulus? Is there tethering or apical displacement of the leaflets? All those things help determine whether there's something beyond just a leaflet abnormality. I don't know this is going to work with just one view, so please keep your eyes very sharp on this one. Whoa, that didn't work at all. This is Jeopardy, isn't it?
These are getting harder.
Yeah, they're getting a lot harder, yeah.
Especially for the conventional guy.
It worked last night on the, this is the 13th. Okay. I think we'll just skip by there. The whole, thank you. Okay, and the next one, please. Yeah, can you play those ones? So I would say this is a patient with very long-standing atrial fibrillation, significant left atrial enlargement, and mitral valve leaflets that aren't quite normal. So, is this primary, secondary, or mixed?
Mixed.
Yeah. I thought this was a good example of mixed. And I found an article, actually, in 2016. This is a Japanese journal looking at patients with long-standing atrial fibrillation who were undergoing TEs. And they excluded those who had bad ventricles, big ventricles, and so forth. And they separated those in terms of the people who had sort of so-called unexplained mitral regurgitation versus those who have very little mitral regurgitation. And what they found was that if you look at the group who have a lot of mitral regurgitation, they tend to have a lot of similarities. Because of the annular stretch, there's displacement of the annulus in a posterior fashion, flattening of the saddle shape of the mitral valve. And what they describe, can I have my mouse here? Whoops. Whoa. Here, a little bit of what they call a little tethering, mainly of the posterior leaflet. And I think we see that in our patients. And what they describe that is something they call hamstringing. So the mitral valve is a bit tethered. It almost looks like a rheumatic valve, although I showed you the short axis. There was no commissural fusion on that particular picture. And this is one of the mechanisms, what they call atriogenic functional mitral regurgitation. So to describe what we already know, that when you have an atrial abnormality, you can have an annular stretch, but the displacement of the annular stretch occurs in such a fashion that actually produces a pattern of mitral regurgitation, where the closure point of the mitral valve is actually a little bit more towards the posterior valve, posterior annulus, and the mitral regurgitation is a little bit posterior in terms of its origin. Not quite jet hugging, but certainly not central. And if you look at our example again, I think you'll see that. So again, a little bit of tethering of the posterior leaflet, and then can you go to the color picture, please? Yeah. So I think that was an example that's of mixed mitral regurgitation, again, with this mechanism as described. So let's move on to how much rather than how come. When we gave this workshop 20 years ago, we talked about the different methods. I think we were introducing the concept of PISA back then and going through the different calculations. And these are standards that people use now in terms of color flow, PISA continuous, pulse wave Doppler, pulmonary vein reversal, consequences on the chamber and regurgitant volumes. So nothing has really changed in terms of two-dimensional echo. Some of these techniques have been refined in three-dimensional echo, but our lab, despite being an academic lab, doesn't really have the best equipment for 3D. So we're still relying on a lot of the same techniques that we were using before. I think that's maybe sad, but true. And putting it together in terms of whether you think it's mild, moderate, or severe, there's really no one algorithm. So I don't think any artificial intelligence can come up with an algorithm because we haven't figured it ourselves. It really is a gestalt looking at all these different elements in there. Certainly we do use quantitation as much as possible, but quantitation I think it carries a little bit of a grain of salt. Oh, here's one. This is Dave Buick's favorite topic. Is Dave here today? Well, he's coming tomorrow, I know. Do you guys distinguish between trivial and mild mitral regurgitation routinely in your reports? So how many would say yes? And how many would say no, that they lump it all together? I think the Americans would say it's actually very important because trivial mitral regurgitation doesn't need to be followed. Mild mitral regurgitation may be associated with pathology. The Canadian guidelines don't really distinguish between trivial and mild. I try to do that and tell my students to do that as well, mainly because I think trivial is no more than anybody else that age with that mitral valve should have, and it really is not really a disease. So I think distinguishing it is helpful for your referring physician. Chronic mitral regurgitation by echo, they talk about different things, and really they talk about an algorithm of how to use different quantitative techniques. But rather than going into the algorithm, I just want to show you some of the pitfalls. Here's one that we know. Color gain is important. You can dial up a jet depending on what your color gain is, and depending on what your Nyquist limit is and your transducer frequency. You can make any jet look a lot worse, any jet look a lot better. So be very mindful of those aspects when you're doing the study. The most important one being the Nyquist limit. And we oftentimes would change the Nyquist limit when we're doing PISA. Just remember to move it back to usual conventional baseline for your next examination. This is a view that the ASC recommends, and Quan taught me this a long time ago, is looking at the mitral valve in cross-section. This gives us an idea of not only what the mitral valve anatomy looks like, but also the pattern of regurgitation. Sometimes we can see multiple jets if it's functional mitral regurgitation. If there's annular stretch, we can see regurgitation throughout the entire annulus, and that can be very helpful. Even in situations of mitral valve prolapse, I think you can help identify which segment is prolapsing, looking at where the origin of a jet may be. This is our favorite PISA method. Tony talked about this, and I know that some labs are much more rigorous about quantitative than others. I think the two reminders that if you're using the PISA method, always use a CW first. That gives us an idea of the jet density, which is a nice qualitative feature. And also it looks at the timing, and you want to try to match that timing with the jet, if you can. This is an example of one where the mitral regurgitation velocity or the blood pressure may affect the color jet. And if you didn't use PISA, you didn't correct for the jet density and as well as the velocity, you might overestimate the severity of regurgitation just because you think the color jet is very, the velocity map shows a lot of regurgitation when actually the velocity map doesn't show a lot of flow. In the last few years, I can recall at least 1 or 2 patients going to the operating room because of a false impression of mitral regurgitation. Unfortunately, both patients, the discovery was made in the operating room and surgery was averted. But be very careful about looking at color jet. And the main method in PISA here is not a very dense jet and a very high velocity, so we might overestimate the MR if we didn't account for that. I'll just skip through that. The jet density as well as PISA also helps us with non-holosystolic mitral regurgitation. If you have mitral valve prolapse with a late systolic jet, even though the instantaneous ERO might be quite large, you know that there's not much time for regurgitation to occur, so the actual regurgitation volume is actually going to be quite small. And if you don't have a holosystolic jet, no matter how big your PISA jet is, it's probably not severe mitral regurgitation. Regurgitation volume, we don't do this routinely. I would just put that forward. Regurgitation volume is using a lot of the same kind of methods that we talked about with aortic stenosis already, calculating the flow through the LVOT, and then also using the mitral annulus to do the same thing. Remember, the mitral annulus is not circular, so you have to do this in more than one plane. It is a bit laborious, and I think fortunately we have other techniques that allow us to calculate regurgitation fraction a little bit better than just regular transthoracic. So what if your transthoracic is insufficient? What should you do? Should you always jump onto a TE? Should you do an MRI? Should you do a CT? I think a lot of this is, you're going to have to ask yourself what the question is. The TE may be insufficient, but in what way is it insufficient? And what question are you trying to answer for which TE is not able to give you that answer? Is it purely, someone you want to look at the quantitation and you can't get a good regurgitation volume estimate and the other parameters are insufficient? And I think if that's the case, there may be some role for magnetic resonance. We know that we can calculate volumes a bit more accurately using MRI, and certainly we can, our lab is using MRI a lot more in equivocal cases to take a look at the actual flow as well as the chamber volumes, which may be helpful in serial assessment of the patients. Skip that. Oftentimes the question isn't just the severity or quantitation, it's also the mechanism as well as the severity, and TE may be very helpful for that. TE, as you know, because of the better image resolution, is helpful for not only looking at mitral valve anatomy and the surrounding structures, but also makes PISA determination a lot easier, vena contracta imaging a lot easier, looking at pulmonary venous Doppler flow reversal, very helpful. But again, the big pitfall is if you don't account for the blood pressure, especially with sedation, you may, if anything, underestimate the severity of mitral regurgitation because you haven't factored the fact that the blood pressure is actually quite a bit lower than during your transthoracic study. Here's an example here of mechanism. So on a transthoracic, it looks like that there may be a perforation of the mitral valve of the anterior leaflet near the lateral commissure, but on T you can see that in this patient who's had a previous endocarditis, there's actually an aneurysm of that portion of the mitral valve leading to the regurgitation. And that would have been very hard to see on transthoracic. I think this is the patient that had the transthoracic and then went to the operating room because they were symptomatic. You see the color jet is relatively impressive. The CW actually is not a very dense jet. And in the TE pictures, again, you can see that there's some cautery going on already during the time the TE is done. But the mitral valve leaflets actually look pretty good. There's central regurgitation in a functional manner. And the degree of regurgitation on the color jet was actually not impressive. The patient was taken off the table. Lastly, is the question related to symptom correlation. Oftentimes the patients are not symptomatic during rest, and the degree of regurgitation may not be very impressive during the time that the patient doesn't have symptoms. So we may want to provoke the patient in some certain situations. How many people have a setup for using stress echo, particularly exercise stress echo, to look for mitral regurgitation and severity in their lab? Okay, so small percentage. And this is just right out of the ASC document. It is very helpful, and the things they want you to look for is a rise in pulmonary pressure as well as an increase in the ERO. And the same parameter that we said is going to be a little bit problematic to quantify. There's no role for pharmacologic stress echo because basically there's too many things going on with dobutamine to be helpful. You really want to get exercise. Arsene, I think you're probably using a bike in yours, yeah, and that is the gold standard. We have a treadmill, we can't afford a bike, but you know what we do, we can. So in terms of learning points, and I notice I stayed on time here, look at the overall picture. So that much hasn't changed in 20 years, which is still, echo is still a very comprehensive and yet semi-qualitative and quantitative examination looking at all the different parameters. Recognize the pitfalls with each parameter and I don't think you can actually hang your hat just on one particular gold standard like an ERO. Each of the factors have strengths and weaknesses. You need to know what question is being asked in order to supplement the patient care. Is it transesophageal echocardiogram to looking at mechanism as well as severity, or is it purely looking at chamber volumes, in which case MRI may be helpful? And above all else, answer the questions how come as well as how much. Thank you.